Hello, good evening, and thank you all for your patience. I think we can start off now. I welcome you all from the Brainchild Trust. Dr. Ashu, over to you now.
Thank you so much, ma'am. Good evening, everyone. Welcome you all for today's webinar on the topic hip surveillance in children with cerebral palsy. Enlightening us on the topic is our own speaker, Dr. Jayanth Sundar Sampath. He is a renowned orthopedic surgeon. He has fellowship in FRCSED and FRCSED trauma and orthopedics. FRCS degree from Royal College of Surgeons, Edinburgh, 1997. He is a faculty member of MCH Ortho program at Wrightington Hospital, UK. He is member of Pediatric Orthopedic Society of India, Bangalore Orthopedic Society, Carnatic Orthopedic Association, and Indian Orthopedic Society, UK. We welcome you all, sir. Please proceed with the sessions. Thank you.
So, thank you so much to Dr. Ravi Kumar and to Dr. Gauri for inviting me. Hip and cerebral palsy is a very topical issue because about 10 different national organizations last year, we all got together and we came up with some hip surveillance guidelines that are specific to India. And I was part of that surveillance drafting committee. So I think now that we have guidelines that are relevant and applicable to India, I think this talk is perhaps coming at the right time. So thank you for the invitation. Can I share my screen? So everybody is able to see the screen and hear me clearly?
We can hear you. The screen sharing is yes, your screen is also shared now.
Great.
All good, sir.
Thank you. So my journey with hip surveillance and hip and cerebral palsy started with this consensus meeting that I was a part of when I was a consultant in Liverpool. This was 13 odd years ago. And every single person who is an international kind of authority on the management of the hip and cerebral palsy came together in this meeting. And this is where we started the concept of drawing up some guidelines at a national level. So I was a very young consultant at the time, and it really was very helpful to me in forming a lot of my opinions over time with regard to the hip. So we all know that cerebral palsy is a generalized disorder of which the musculoskeletal system is affected to a significant extent. But other problems are the epilepsy, problems with vision, speech, and many of them have problems with eating and nutrition, all of which have a bearing on the overall management of the hip when we come to treating these as surgeons. So in addition to all the general features, there are primary, secondary, and orthopedic problems. The primary problems are mainly weakness associated with spasticity. Children also have loss of motor control, problems with balance and coordination. But it is a good thing that it is a static encephalopathy, but the musculoskeletal problems tend to worsen with growth. As the bones tend to grow in children with CP, the muscles do not cooperate, they do not lengthen and result in contractures. This causes secondary joint contracture. And then because of the lack of mobility of these children, they develop scoliosis, foot deformity, torsional deformities, and hip displacement. So the musculoskeletal problems do tend to worsen as the child gets older. In addition, children also have tertiary problems, which are compensations that develop in order to in order for the child to walk. So spasticity is a velocity-dependent increase in tone, and spasticity follows a very typical progression over time as the child gets older. It is low to normal at birth. It steadily increases to age 4, and age 4 to 5 years is when children with CP typically come to us, and they have maximum spasticity. And then after the age of 4, there is a natural decrease in the amount of spasticity until the age of 12 years. And this has been documented in population-based studies, which shows that spasticity increases to a maximum between 4 to 5 years and then gradually decreases over time. This is important to understand when we treat spasticity, that spasticity will tend to go down over a period of time. But the contractures do tend to worsen with age because longitudinal bone growth is near normal in CP, but the muscle is unable to lengthen in pace with growth. This causes dynamic muscle contracture increase initially, leading to a static muscle contracture at a later stage. And the final stage is when you develop a fixed joint deformity, best illustrated in the knee as a fixed flexion deformity, which is very common, and also hip displacement. So I'll just skip through these lever arm dysfunction slides. But one of the important problems is coxa valga, which has been implicated more recently in more recent research work as being a primary problem, which is responsible for hip displacement. In addition to causing hip displacement, it also causes problems with gait because it shortens the abductor lever arm. You also have a mal-rotated lever arm, femoral anteversion, and this can also cause problems with both gait and it can increase the amount of hip displacement. Once the hip starts to dislocate, the fulcrum of the hip is displaced laterally, and this again causes problems with walking and decreases the mechanical efficiency of the hip. So this is work from about 10 years ago that showed how proximal femoral geometry is altered in CP. So about 20 years ago, we used to think that spasticity was the cause of the hip displacement, that the hip flexors and the adductors were tight because of spasticity, and that caused the hip to come out. Now, about 20 years ago, that concept started to be revised when we found that there was a strong association between GMFCS level, which is the mobility level of the child, and the risk of hip displacement. And then we started going off spasticity as being the cause of hip displacement to GMFCS level, lack of mobility being the cause. Now, from that second stage of understanding, we now have reached a third stage of understanding where the latest evidence appears to suggest that coxa valga and femoral anteversion is the root cause or is the morphological problem that is responsible for hip displacement. So this is a study that was done in Melbourne, which showed a progressive increase in the femoral neck shaft angle with increasing GMFCS level. So children with GMFCS level 1, near normal independent walkers with CP had a neck shaft angle not too different from a typically developing child. Whereas at level 5, a non-walker, you can see that there is a significant increase in the neck shaft angle. So proximal femoral geometry appears to be an important factor in hip displacement, in addition to lack of mobility, and maybe spasticity plays a very small role in the etiology of hip displacement. So you can see how there is a almost linear relationship between the femoral neck shaft angle, the femoral neck anteversion angle, and the migration percentage, which goes almost in step with increasing GMFCS level. So lack of mobility, which causes abnormality in proximal femoral geometry, seems to be the underlying pathophysiological mechanism of hip displacement. So now we know that when children do not walk properly, their hips start to displace. In addition, there is weakness of the hip abductors. As I said, maybe a small role from spasticity of the hip flexors and adductors. And now, with the latest evidence, we know that there are abnormalities of proximal femoral geometry. So we know the clinical features of hip displacement. I think as therapists, everyone is quite familiar with what to look for. Children start to lose abduction and develop an adduction contracture. if there is an established hip dislocation or subluxation, one can measure a leg length discrepancy, particularly in the femoral segment. In later stages, as the hip starts to dislocate, you can get pain during movement. In the early stages, hip displacement is typically silent and asymptomatic, and therefore, physical examination is frequently inadequate and unreliable in order to detect early hip displacement. And this is a very important point that therapists need to bear in mind. So these are all very common clinical features that we see. In terms of radiology, I think Reimer's migration percentage has become the worldwide gold standard as a measurement, as an objective measure of how much hip displacement there is. And it also gives us some idea as to when to initiate treatment. And it has been validated in multiple studies as being reliable and reproducible. So I think even as therapists, you should start to learn to draw these lines. You can always rely on a radiology report, but if you are the treating therapist, it's very, very simple. And you can do it if you have a pencil and a ruler. So you draw something called the Hilgenreiner line, which is a line that is a horizontal line that goes between the triradiate cartilages. And then we draw one more vertical line perpendicular to the horizontal line at the medial edge of the femoral epiphysis, one at the lateral edge of the femoral epiphysis, and one through the lateral edge of the acetabulum. And if you have any doubts, there is an app which I will talk about later, which tells you how to draw these lines. But it is something that can be done by a therapist, I feel. I don't feel that this is beyond the capability of a therapist to do. And once you start to see a few x-rays and measure it, I think you can do it. You can also get a formal radiology report if you wish. So this distance, the portion of the femur that is femoral head that is outside the acetabulum is x, and the entire width of the femoral head is y, and x by y times 100 is the Reimer's migration percentage. It's basically the percentage of the femoral head that is outside the two bony acetabulum. And changes in and stability of the Reimer's migration percentage is probably as important as a single measurement. So if you have a Reimer's migration percentage of 25 this year, and then it goes up to 32 next year, and then the following year it's 38, then you know that you have a problem where the femur is gradually displacing out of the acetabulum. So who is at risk? Every child with cerebral palsy is at risk of hip displacement. And this is an important point to bear in mind. Obviously, children who have a higher GMFCS level are at a higher risk, but technically every child with CP is at risk. In particular, if a child has not taken 10 independent steps by 2.5 years, 30 months of age, the risk of hip displacement increases. When the migration percentage crosses 30%, not 30 degrees, it's 30%, the risk increases. Obviously, the non-walkers, GMFCS levels 4 and 5. And girls also seem to be particularly, they are more prone to hip displacement compared to boys. So this is a very important study, a seminal paper from 2006, again from Melbourne, that showed that as GMFCS level increases, there is a almost linear increase in the risk of hip displacement. And the other important conclusion from the study is that the severity of the spasticity did not predict hip displacement. So there is no direct relationship between the severity of spasticity and the risk of hip displacement as much as GMFCS level. So many children with hip displacement are asymptomatic, but in the later stages, they can have problems with seating, perineal hygiene. They may develop pain during therapy or when you're trying to stand them, or even in the seated position, some children can get pain. There is some relationship between an established dislocation of the hip, which can cause pelvic obliquity, and in response to the pelvic obliquity, there can be evolving scoliosis. Though in GMFCS level 4 and 5 children, they are independently at a higher risk of developing scoliosis. So the causal relationship between hip displacement and scoliosis has not been, I would say, firmly established, but there may be some relationship between the two. Because with practical experience, I'm sure many of you will know that many children with hip displacement also have a scoliosis. But whether the two are directly related or not is, it's not still been completely worked out. So in terms of prevention, which is very important for therapists, good positioning is important. It's important to avoid wind sweeping. As you can see in this particular child, one hip is in adduction and the other hip is in abduction. And this kind of wind swept posture is definitely not good for the long-term longevity of the hip. Proper tone management and prolonged standing frame use, particularly in non-walker, are all known to have beneficial effects. So treatment options start from non-invasive, going all the way to the most invasive surgical treatments. So standing frame, postural management, the use of abduction orthosis and selective use of botulinum injection to try and relieve the adduction contracture are all valid treatment measures. If non-operative treatment fails, then we initially start off with soft tissue surgery, mainly releasing the adductors and the psoas. The next step is to do rotational varus osteotomy of the femur. And in established cases where there is frank dislocation of the hip, we do something called hip reconstruction surgery, which is femur and pelvic osteotomy. There is no real consensus in the literature on an exact indication for surgery, but generally, if the migration percentage crosses 40%, along with progression over time, we generally feel that surgery is indicated. But there are few long-term studies with follow-up up to skeletal. So, but the data is coming in as we start to do more long-term longitudinal studies following up children who have had surgery. So, at an early stage, in a young child with early but progressive subluxation, we generally prefer to do only soft tissue releases, because if we do bony surgery in a younger child, say less than 6 years, they have a very high chance of recurrence of the subluxation and requirement for a second osteotomy, which we always try and avoid, because doing an osteotomy a second time is far more difficult. Whilst Botox and bracing do not seem to have any long-term effect on the natural history in a randomized controlled trial that was again carried out in Melbourne, there is some evidence that if Botox and bracing are instituted judiciously in a younger child, it may at least buy us some more time, so that if surgery is required, it may be performed at a slightly older age, and therefore the longevity of the surgery may be slightly better. So the question really that we are asking ourselves as orthopedic surgeons is whether preventive surgery is effective. And if we use the need for bony surgery as an endpoint, Miller et al., under whom I worked, 25 years ago, he showed that there was a 2/3 reduction in the need for bony surgery. And Kerr-Graham from Melbourne also showed that the total number of interventions increased, but the amount of more invasive or major surgeries reduced, but the soft tissue surgeries increased. But this is a long-term longitudinal survivorship analysis, and it showed that children who need soft tissue surgery the most, which is the GMFCS level 4s and 5s, that is the dotted line here, they seem long-term to benefit the least. So if you do soft tissue surgery in a GMFCS level 1, 2, or 3 child, they seem to have some marginal benefit. But the ones that really need it, the GMFCS 4s and 5s, if you follow them up for long enough, they all start to displace again. But the advantage of doing soft tissue surgery is that you can buy about 4 to 5 years of time. So this is an example of a 3-year-old bilateral GMFCS level 4, had a migration percentage of more than 50% when they came to me. And we do soft tissue surgery, and we always do it bilaterally. And I just thought, as therapists, it would be interesting for you to have some pictures of what we do during the surgery as well, because Many of you may not have seen these operations. We release the adductor longus and the gracilis, and then we also crush or we put some phenol on the obturator nerve, on the anterior branch of the obturator nerve, and then we put them in a cast for about a month post-op. So this is the same child at 12 months post-op. You can see that the migration percentage is reduced from 50% pre-op to less than 30% post-op, which is a significant improvement. And then this is at 2 years. You can start to see the migration percentage creeping up again. And then this is when the child is 8 years of age. This is 5 years post-op. And you can see that the migration percentage has reached 50% again. So you might think, well, the migration percentage was 50% pre-op, and 5 years later, the migration percentage is again 50%. What is the benefit of surgery? The big benefit of the operation of the soft tissue surgery that was carried out is that it has bought the child 5 years of time. So if we do bony surgery in a 3-year-old, that's not a good idea. But now that the child has become 8, we can do effective bony surgery. So what the soft tissue surgery does is to buy us 4 to 5 years of time, which is valuable. So one can see, going back to the previous slide, that the GMFCS level 4s and 5 children in the long term will need further surgery. They do not appear to completely abolish the need for further surgery. So what do? We do bilateral femoral and pelvic osteotomy. We put big plates in, and then child goes in a hip spica for about a month. So it's a really significant intervention for the child. I tell parents that this is a life event. But if the surgery is carried out properly, if it's carried out competently, you can see that it becomes much easier post-op for the child to sit, for the child to be in a wheelchair, and also for the carers to be lifting and carrying the child. So recurrence rates are higher following reconstructive surgery if you do it in younger children. So, and if we are going to do surgery, it's better to do femoral and pelvic osteotomy. The overall failure rate is between 15 to 20%. So it's not something that as surgeons we take lightly. This is a very big decision both for the family and the surgeon before we proceed with this kind of surgery. So there is a significant complication rate. Many of these children have problems with respiration. They have poor bone quality, which tends to result in loss of fixation. Sometimes these implants can break, and there is a chance of redislocation, though with properly conducted surgery, the risk is less than 5%. They develop pressure sores, and some of them go to the ICU. So bony surgery is not something that we would take lightly. We generally give ourselves 3 to 6 months time in order to prepare the child for the surgery. In some children, even after reconstruction, even after bony reconstruction, they can develop redisplacement, and there are operations we can do to correct that as well. So these are examples where only one hip was fixed, and that is not a good idea. Generally, it's a better idea to do bilateral hip reconstruction. And this is a child who is now about 3.5 years after surgery, and he's able to stand for therapy and transfers. He's a GMFCS level 4. So a new technique has come, which is called proximal femoral growth modulation. And this involves just putting a single screw through a very small incision into the proximal femur. And early results show that there is a lot of value in doing this particular operation along with the soft tissue surgery. So there is some data in the literature now to suggest that just by putting a small screw into the medial part of the proximal femur, we can achieve the same effect over a longer period of time as doing a major osteotomy. So this is the new procedure that we have also in Rainbow Children's Hospital, where I work. We have done about 10 cases now over the last 1.5 years, and we are starting to see some good results with this. So in terms of non-operative treatment, there is good evidence to suggest that a standing program reduces the severity of hip displacement, particularly in GMFCS level 3 CP. if you have appropriate postural management, fewer interventions were required for hip displacement. And if a hip abduction brace is going to be used, if it is worn for at least 12 hours a day, it appears to have some significant improvement in the migration percentage. Now, what we are really trying to avoid is all these salvage procedures where we resect the proximal femur or we do valgus osteotomy and things like that. These salvage operations, I feel, are obsolete, they are outdated and should be avoided. Scoliosis, I mentioned about, that it coexists frequently with hip displacement, but whether it is causative or coexisting, we don't know. Some of these children, if the scoliosis becomes really severe, we have to do spinal fusion surgery. So I think of this as a ladder of reconstruction. Up to 18 months, we, at 18 months of age, we start with a hip surveillance program and non-operative measures. In children where there is progression of hip displacement under 5 years of age, I feel soft tissue release is a good option. And then 6 to 10 years, I told you about this new technique where we just put a single screw. And in children over the age of 8 years, where there is an established dislocation, we have to consider bilateral hip reconstruction surgery. And then we can do some minor surgery if there is a recurrence up to skeletal maturity. But what we want to try and avoid is this disaster of these salvage surgeries. And the way to avoid children from requiring salvage surgeries is to do regular hip surveillance. And that is the kind of main point behind this lecture. But I just thought telling you something about the background of hip displacement and the factors that affect hip displacement, I feel is important before we look at why we need to do a surveillance program, because a surveillance program is not a simple thing. It involves a lot of effort, particularly from therapists. So if you are going to take all that effort, I feel in your own minds, the reason why we have to do it has to be justified. And therefore, I gave you a kind of quite a detailed run-up to why we need to do this. So hip surveillance should be started in all children with CP between 12 and 24 months, corrected age. Most surveillance programs in the world say that we will start at 2 years, but as soon as CP is diagnosed, you can perform a proper examination of the hip and do a hip X-ray and start the surveillance program. You don't have to wait until 2 years of age. So the frequency of follow-up depends upon age, GMFCS level, clinical examination, and the Reimer's migration percentage. So these are the 4 variables based upon which we will decide the frequency of follow-up. Now, typically diplegics, children who have bilateral CP are at risk of hip displacement. Hemiplegics are not at a high risk of hip displacement, except this group 4 hemiplegia, and we will look at what group of hemiplegia is. And we already learned that soft tissue surgery in younger children postpones the need for bony reconstruction. But the key is to identify it early and prevent hip dislocation altogether. Yeah. And obviously, as I mentioned, abolish the need for salvage surgery. So this is something I would like all of you to do. Please, after this talk, go to Play Store or the App Store, or if you have an iPhone, and download this app called Hip Screen. It is specifically meant for screening, for running a hip surveillance program. And it has all the data and all the tools that you need in order to run a successful hip surveillance program for your children who are under your care with cerebral palsy. So in addition to that hip screen, I also would like you to visit the Pediatric Orthopedic Society of India website called posi.in. Just Google Pediatric Orthopedic Society of India and look for this National Cerebral Palsy Hip Surveillance Project. So a number of associations, the IACP, the POSI, and physiotherapy, OT associations, and the AOCN, all of us joined together with the IOA and the IAP in order to evolve detailed guidelines for clinicians in India as to how to deal with hip surveillance program in the Indian context. So hip surveillance is a schedule of regular clinical and X-ray examinations that can identify silent hip problems so they can be treated earlier and more effectively. So hip surveillance has a proven record of improving a child's function in several high-quality population-based studies, and it is becoming the standard of care around the world for children with CP. So if you want to provide the worldwide standard of care, having a hip surveillance program is essential. So this is just data from Sweden that shows that you can completely eliminate hip dislocations in your population if you have a proper hip surveillance program. So all the guidelines are there. So there is guideline from the US, Australia, from Canada, and from Sweden. And all of these, most of them are very similar, but the complete guidelines are available in the app. So you can just go through the app and read through the surveillance guidelines. So all of you know about the GMFCS levels. And for purposes of the hip surveillance program, we have divided them into 3 categories. GMFCS levels 1 and 2 are the first category. GMFCS level 3 is a separate category. 4 and 5 are another category. So we have 3 different categories. The blue triangle means clinical exam. The green square means you have to do an X-ray. And the columns are basically the age of the child in years. It starts at 2 years and goes all the way to skeletal maturity. Excuse me. And for each category, it tells you at every age what you have to do. Whether you have to do a physical exam only, or you have to do a physical exam and an X-ray. And this chart is downloadable from the POSI website. And you can just take a printout of this and just stick it up in your clinic so that you won't forget. But once you become familiar with this schedule, I think you won't need the chart because you'll know what to do. So when should you refer to an orthopedic surgeon? You can refer to a pediatric orthopedic surgeon if you have access to one, but even an orthopedic surgeon who has an interest in pediatric orthopedics is sufficient if you don't have direct access to a pediatric orthopedic surgeon. So when the migration percentage on the X-ray is over 30%, you should refer. When the hip abduction range decreases less than 30 degrees, when there is any hip pain or decreased function, when there is a reduction in the range of movement of the hip, or when there is asymmetry. So these are all the criteria when you should make a referral to an orthopedic surgeon. The most important thing as a therapist is to measure this combined hip abduction angle. So it's called CHAA. And if the abduction in either hip is less than 30 degrees, then that is an important criterion. And this is best measured with the pelvis squared. And please use a goniometer to make this measurement. And if you are going to, I know that some therapists are now ordering X-rays as well. So if you are going to order an X-ray, kindly make sure that if the child has a hip flexion contracture, you please tell the radiographer to put a little cushion under the calf in order to flex the hip up so that we can get a neutral pelvic X-ray rather than a pelvic X-ray where there is rotation of the pelvis, anterior rotation of the pelvis, and this can affect the quality of measurement of the Reimer's migration percentage. So just to summarize the talk, hip problems are common in children with CP. Many hip displacements tend to go unrecognized, particularly in India, but frank dislocations are entirely preventable as demonstrated by the Australian and Swedish long-term data. All clinicians, particularly therapists, should use hip surveillance guidelines in their day-to-day clinical practice. And what we are hoping to achieve as orthopedic surgeons and as a community of clinicians taking care of children with CP, what we are really trying to do is to abolish the need for major reconstructive and salvage surgeries for children with CP. So thank you very much, and I think I can take questions.
Thank you, sir, for that wonderful presentation. I now open the section where the audience can unmute and ask questions to Dr. Jayanth.
So I had some questions that Dr. Ravikumar had sent me.
Would you like to go through those first, sir?
Yes. Do you have them to hand? You can ask the
Yes,
question.
sir.
And
Yes, I'll do that.
Yes, Ms. Apurva will ask the questions, so not issue. So in the meanwhile, you can post them in the chat box or raise your hands. We'll come one by one to the questions. Over to you, Apurva.
Thank you, ma'am. So we have one question from Rogina. She wants to know why it is important to do hip surveillance. Why is it important to do it?
So the importance of hip surveillance is basically to prevent major surgeries on children with CP. That is the underlying reason why we are doing it. Because if you don't do hip surveillance, many children with CP will develop frank dislocations, and we need to do major reconstructive surgery. But this is completely preventable. So Australia and Sweden, they have no incidence of hip dislocation. The incidence of hip dislocation in Sweden is 0 in children with cerebral palsy, and that's a huge achievement. Obviously, Sweden has a public healthcare system, and they have a national health service, and they have guidelines in place, and they are properly resourced. So, trying to extrapolate the Swedish situation directly to India probably is not fair or appropriate. But I feel the fact that 40 odd clinicians have, taken the trouble to log in and listen to a talk on hip surveillance means that there is the enthusiasm and there is the recognition amongst clinicians that this is an important problem and we need to address it. So all we need to do now is to spread the message to more numbers of therapists, because orthopedic surgeons, we see, and even neurologists for that matter, we see children with CP once every 6 months or once a year. Therapists, you see them several times a week. So I feel that even in Sweden and Australia, therapists run the surveillance program. The main people who are the kind of directors and the coordinators and organizers of the surveillance program, they are all therapists. So I feel this is a therapist's job. And obviously, once a child has been picked up as being at risk of hip displacement, and once those criteria are fulfilled, then obviously orthopedic surgeon and other specialists, physical medicine, rehabilitation specialists, and pediatric neurologists, we will all get involved. But primarily, I feel that this is the responsibility of therapists to actually run the program. Whether you have 5 children with CP, you have 50 or 500 children with CP, I feel that all of those children should have some kind of surveillance program that you run in your individual practices. So the reason for doing it is to avoid surgery, and the reason for doing it is it's preventable. Let's say that there was a problem that you could not prevent, right? Then there's no point running a surveillance program, because whether you run surveillance or not, the hips are going to dislocate. But here we have a validated measure. Just by doing a simple X-ray, we can actually identify the problem early, treat it, and prevent this dislocation. So it's a very, very important problem.
Thank you for that, sir. Another question from Lucy. How frequently should we screen for hip dislocation?
So I referred to that chart. Please download that chart, and the hip surveillance.
The link for the chart I have posted in the chat box, the
Perfect.
National Cerebral Palsy. So over there, the chart Dr. Jayanth had put up in the slide is there in that link. Just go through the two links that have been posted. And Apurva, maybe we can next take up the question in the chat box and then go back to the offline questions.
Yes, ma'am. So, Dr. Priya Kuberan wants to know, are there major differences in hip surveillance principles for children with hypotonia or ataxia without spasticity or tightness being a clinical presentation?
So, no, there are no major differences because, as you have seen, the type of movement disorder is not a factor at all. It's not a criterion at all to determine whether a child is at risk of hip displacement or not. So there are only 4 factors. One is age. The second is GMFCS level. Third is what is your range of hip abduction when you do a physical examination. And fourth is Reimer's migration percentage. So age and GMFCS level are far more important to the risk of hip displacement compared to the type of movement disorder. So a GMFCS level 5 child with ataxia or hypotonia has a higher risk of hip displacement than a GMFCS level 1 child with spasticity. I hope that makes sense. So the type of movement disorder does not really matter. So what matters more is GMFCS. And even the severity of spasticity doesn't matter. So you can have a child who has very little spasticity, but who is not walking, they will develop hip displacement. Whereas you might have a walking child who has severe spasticity and their statistical risk of developing hip displacement is a lot less. So it is the GMFCS level that primarily determines your risk of hip displacement.
Thank you, sir. We have a question from Nayana. How to handle severe hip abductor spasticity?
So hip adductor, so spasticity is something that does not always need to be dealt with unless it is causing some abnormal effect. So either it is interfering with the child's gait, or it is interfering with the ability of the carer to handle the child with perineal hygiene, or you are not, as a therapist, you are not able to progress to the next stage, whatever is the next stage of the child's development. You feel that the spasticity is hindering your efforts at providing proper therapy to the child, or if on an X-ray the child is developing hip displacement or some such thing, spasticity in and of itself, if it is not causing any trouble, you can just leave it, because as we saw in one of the slides, spasticity tends to be low or near normal at birth, and then it increases up to age 4 to 5, and then naturally decreases over time. This is the natural history of spasticity. So unless it is causing trouble, you don't need to deal with it. If it is causing some problem, either with the child's function or with hip displacement, then we start off with, again, postural measures. We start off with using a standing frame and things like that, and then progress on to maybe giving Botox injection in a child less than, say, 6 or 7 years of age. We can combine them with hip abduction bracing. And then in later stages, if there is an established contracture, then we can think about soft tissue surgery. So it's a kind of, as I showed, it's a ladder of reconstruction. You start off with the non-operative measures and gradually increase it as the problem becomes more severe and as the child's age becomes older.
Thank you for that, sir. We have another question from Sana. She's also a physiotherapist. For a child with hypotonia, what kind of X-ray has to be suggested?
The same. For all children, the X-ray is the same, which is just a simple plain pelvis X-ray AP view with both hips. So that can be done in any local hospital or diagnostic center. So it's just a simple AP X-ray of the pelvis with both hips. But remember that you have to tell the radiographer that if there is a significant hip flexion contracture or an anterior pelvic tilt, you just need to put a little cushion just to flex the hips up so that the pelvis will rotate posteriorly and you'll get a true AP view of the pelvis.
We have another X-ray related question from Nayana. Before weight-bearing exercises, is an X-ray required in a child with cerebral palsy?
Absolutely. So you just follow the frequency of follow-up on the hip surveillance program is completely dependent on the age of the child. So you don't have to do an X-ray specifically before you start weight bearing the child. Just go according to the age. So if it's a 2-year-old child, GMFC is level 3, yes, you will do an X-ray. And then GMFC is level 3. If it is, again, you will do it at 6-monthly intervals for the first 2 years. And then if the rhymus migration percentage is stable, then you will do it annually. Whereas if it's a GMFCS level 5 child, regardless of what you're doing with them, every 6 months, you have to do a physical exam and you have to take an X-ray. So it's like that. So it just goes according to the schedule of the hip surveillance program and just follow the chart. And the chart is self-explanatory and it tells you how frequently you need to do these things. So it just goes according to a periodic calendar. And it would be good if you can just create a small, like a table, and then just record all your findings. What is the physical exam finding? What is the migration percentage? And keep it in a chart and then attach it to the child's file so that you can easily see what is the progression. Is the migration percentage increasing over time? Is the range of hip abduction reducing over time? Is the child developing any pain that was not there previously? So it's better to document these things on a single piece of paper so that you can keep track of it over time. Because as you know, in India, parents do not always bring old X-rays and things like that. So, and if it's possible for you to, if you have a stable patient base, you can even keep that file in your clinic and record the findings as the as and when the patients come in, or you can give it to the parents if you feel they are reliable.
Thank you, sir, for that practical tip. We have Dr. Payal. I think she's sharing a case with us. This is a severe spastic quadriplegic child with CP who is on the GMFCS level 5. Is it wise to go for surgical correction or hip displacement in resource limited setting?
So resource limited is a very important point. I'm glad that was raised. Any kind of surgery for a child with CP should only be undertaken by an experienced clinician and in a center where there are good backup facilities in terms of, be it a PICU or, having a good pediatrician. Ideally, if there is a pediatric neurologist in the hospital who can take care of the child, all of these are very essential. If backup is not available, then complications tend to happen, and the outcome may be, you may end up with an adverse outcome. So it would be better to refer it to a tertiary center where all the facilities are available and if surgery is required, that the child can be properly taken care of. Because in a GMFCS level 5 child, they will have seizures, they'll have feeding difficulty, they may have a risk of aspiration, poor bone quality, lots of issues, and a lot of nutritional issues, anemia, low vitamin D. All of these issues tend to coexist in children with GMFCS level 5 CP. So these children require extremely detailed and accurate and a thorough assessment prior to undertaking any surgical intervention. So Yeah, that's a very important point, and I feel in India we need more of these tertiary centers distributed throughout the country, so that more numbers of children with CP who do need surgery can be taken care of properly. Because at present we do not have enough of these tertiary centers to deal with the numbers of children who have CP, and it tends to be concentrated mainly in the metropolis and in the major cities, and access for children, particularly in in villages and in the rural kind of setup, becomes a major issue. And I don't mean just financial, but it's also geographical. So if we have more, even in the government setup and in the private healthcare setup, we need far more numbers of these centers who are able to take care of children with CP properly. So what do? I think you should get in touch with your nearest tertiary center that is able to handle children with CP, and then refer them on, and try and facilitate the at least an assessment by a professional in a tertiary center.
Thank you, sir. We have another question from Dr. Dhanvi. She wants to know how hip abnormalities can affect gait function and strategies for overcoming it.
Two major issues that we tend to have in the hip, which affects gait. One is intorsion, femoral intorsion. And the other issue is hip flexion. So we used to realized that releasing the psoas muscle is probably not the best idea, because if you release the hip flexors, children lose in two abilities. One is stair climbing, because for stair climbing you need powerful hip flexors. And the other particular problem I've seen in India is they are not able to lift their leg up to be sitting as a pillion in a two-wheeler. So, and climbing steps, particularly stepping onto a bus, the stairs in at home tend to be about 3 or 4 inches. They're able to manage that, particularly if there is a rail to hold on to. But getting onto a bus, which is a really high step, tends to become a problem. So we are not doing as many surgeries to deal with hip flexion. We just tell the therapist to try and strengthen the hip extensors as much as possible. The other problem they tend to have is internal rotation. And generally in torsion, we tend to wait until about 7 to 8 years, sometimes 9, 10 years. And if intorsion is a significant problem which is causing in-toeing gait, then a femoral derotational osteotomy can be done. But at a younger age, I feel doing good functional exercises, anti-gravity muscle strengthening, and in the non-workers, putting them on a standing frame and doing a good standing program. All of these are very important to try and bring the anatomy of the proximal femur, the geometry of the proximal femur, as close to normal as possible. So functional exercises, walking, and anti-gravity muscle strengthening, I think, are the mainstay of treatment from a therapist's point of view.
We have the last few minutes left. I have one last question from the registration participants. But if anybody from the audience wants to unmute and ask, please go ahead.
Namaste, sir. This is
Namaste.
Lavanya, sir.
Hello.
Hi, sir. Sir, for a GMF scale level 3, after botulinum injection, if they have been improved, to another level, to level 2, like that. Will that it can be continued with the physiotherapy, or still they may need surgery, or what is the time period to wait, or how much time we can continue the therapy for muscle strengthening and all?
So, so that is something. See, if you read the Western literature, they always say that GMFCS level is stable over time. So, if you're at GMFCS level 3, you'll remain at level 3. But in India, we find that parents do not seek the the help of a therapist at the ideal time, and many therapists will see that the GMFCS level of the child will actually. So what you're doing is actually taking that child to the actual GMFCS level. So if you find that after either therapy or Botox or whatever intervention, the functional level of the child improves, that is the new level is the actual level. And I think you should maintain it at that level, because that is the true potential of the child, which has been brought out by the intervention. Whereas in the West, from a very early age, they tend to have appropriate interventions, and the parents are also, I think, more likely to seek intervention at an earlier, seek therapy or other interventions at an earlier age. So things happen according to whatever is the functional capacity of the child from an early age. Whereas in India, you find that things often are ignored at an earlier age, and only when things tend to really affect the function of the child, they actually come to you. So it's a very, very mixed picture. So, but I would suggest that some therapy should be done in all children with CP almost until skeletal maturity. And whether the therapy is done in a center or done at home, or even in a gym, depending on the age of the child, I mean, that depends on the particular situation that the child is in, the family situation, etc., and where they are, what is their geography, what is their access to local services. But every child with CP should get some regular form of exercise, at least 3 to 4 times a week, possibly for life. Even as an adult, I think individuals with CP should continue to lead an active life and do some form of regular exercise. So the role of the therapist in all this cannot be overstated. I mean, as I said before, you really are central to the whole problem. So I think hip surveillance is one more thing in addition to all the other things you do for the children with CP. I feel hip surveillance is one more thing that I think you should start to do now, and it will have a really beneficial effect on the long-term outcome of that.
Sure, sir. Sure. Definitely, I'll do this. Thank you, sir.
Thank you.
Thank you, Ms. Lavanya. We have time for one last question before we move on to the vote of thanks. Any audience member, please go ahead.
There is one query from YouTube. Let me just read that out. It's from Deepa Pujari. She says a child with spina bifida, age 3, with severe bilateral hip dislocation, ability to perform sit to stand, what would be the best step to progression in terms of surgery and therapy?
So in bilateral spina bifida, it also depends on the level. If it is a higher level, if it's above the sacral level, then generally bilateral hip displacement in spina bifida, which is very different to hip displacement in cerebral palsy. In spina bifida, we generally try and not to do surgery. So if the child has a sacral level spina bifida, has anti-gravity quadriceps function, at least MRC grade 3 quadriceps, and they are showing some potential to be able to walk independently. In those children, in a very selected group of children with spina bifida, perhaps hip surgery can be considered, but spina bifida is a lower motor neuron lesion typically. Cerebral palsy is an upper motor neuron lesion. So results of corrective surgery for hip displacement, particularly bilateral hip displacement in spina bifida, is not as good as the results in cerebral palsy. So the two conditions cannot be considered. So in spina bifida, I would be a lot more careful. I would consider and weigh a lot more clinical features. I would like to follow that child up over an extended period of time, understand what is the true walking potential of the child, and whether surgery will benefit the child, will improve the functional abilities of the child, and also what are the risks of recurrence of the hip dislocation even after surgery. So all of these factors have to be considered in every child before we make the decision to intervene or not.
Thank you very much, sir, for patiently answering all our queries. I now invite Ms. Yamini to propose the vote of thanks.
Good evening to everyone present here. I would like to express my heartfelt gratitude to Dr. Jayanth Sampath for taking the time to educate us on hip surveillance in children with cerebral palsy. I'm sure each one of us have learned something new today and have something to take away from this webinar. I would also like to express my gratitude to the team in making this webinar happen today. I'd like to thank everyone present here who took the time to be with us here today. Thank you.
So thank you so much to everyone for organizing and for this invitation. It was a fantastic interaction, and hopefully we can have more interactions in the future.
Sure, sir. And thank
Thank
you,
you so much.
everybody. Yes, sir. Thank you, Dr. Jayanth. It was indeed a good interactive session, and it was very useful.
Yeah. Thank you. Thanks.